Hi, everyone. Thank you for joining us. This is the first of what will be 6 of our bootcamp presentations. I am Michael Chapman. I'm the Director of Product Innovation at Genova Diagnostics, and I'm a naturopathic doctor by training. And first, I'd just like to thank you all for being here and to Rupa for working on this collaboration bootcamp with us. Super excited to be presenting this information, and I'm sure that you all will find it very, very useful in your learning and growing into being expert in GI evaluations, and especially as it comes to GI testing and interpretation. So we have a little bit of a two-parter today. I'm going to be starting off giving kind of a high level of, what are some of the things to think about when you have a patient with GI symptoms coming into your office? Where do I begin? What are some of the main things I should be looking for? This might be a bit of a review for some people, and it also might help some people to kind of reframe their thinking on GI evaluation in general, and that's a little bit of my goal. And then the second part of this, I'm going to hand it over to Dr. Stephen Goldman, who's also part of our medical affairs team here at Genova Diagnostics, to do kind of a high-level report review, give you a starting place to launch off for the next 6 weeks. So looking forward to sharing this information with you guys, and also getting to know you a little bit more face to face on our Q&A sessions on Wednesday. So with that introduction away, let's get started on talking about GI functions and health and disease, and really kind of how to think about where to begin. So for this presentation, I just wanted to, kind of help you understand kind of the over and underlying functions of the GI tract, to be able to look at GI dysfunction from more of a systems medicine approach. And how do we really figure out what root cause is driving your patient's symptoms with anything in the body, whether that's GI or elsewhere, whether that's nutrition or any sort of chronic disease. A lot of these things are always multifactorial when it comes to root cause. And if we're really trying to get to the root cause of somebody's dysfunction, their symptoms, their pathology, we have to understand exactly what we're talking about and really what the functions are. So with that, I think any good presentation about GI health, you're going to hear this: all diseases begin in the gut. So I actually went online to find where he wrote this so I could kind of get the context. And what I did find were hundreds of blogs where this line was quoted. And just as a sign of the times, half of those blogs were saying, well, Hippocrates was obviously right about that quote. And then half of them were like, well, that's clearly not right. I mean, not all diseases begin in the gut. So with anything, there's always debate. But I think what's not debatable is that a lot of our conventional training is siloed, right? We sort of break apart all of these different systems and specialize in them. And there's not a really great job of being a generalist. That's supposed to be where kind of primary care exists. But what you find is that in primary care, it's more about triaging, and it's not about integrating these different systems. And so when it comes to finding root causes and a systems medicine approach, we have to get really good at understanding how all of these different areas fit together. And so right now we're going to be focusing a lot in the next 6 weeks on gastro, but just keep in mind in the back of your head that we're always trying to think about what does gastro play into, and what things lead to gastro dysfunction. And we'll get into some of that today as well. And I always like to take a little bit of a step back when I'm trying to kind of reframe and go into a new area of thinking. And maybe this is kind of your first, or you're a beginner getting into functional medicine or systems medicine, root cause medicine. So what exactly is the role of the GI tract? And I think a lot of people would answer that with, well, it digests, it absorbs, it handles some inflammation. There's a lot of immune activity there. There's this whole microbiome thing. And I say, okay, those are functions in a way, but they're more methods. You know what I'm saying? That's how we get to what the gastroenterology, what the GI tract is trying to do. And so if I take even one step back from that, I would say that ultimately the GI tract's role in the system is to maximize assimilation of nutrition at the highest efficiency, right? Is trying to take in things from our external world to incorporate them, and is trying to do that very efficiently. But when you take things in from the external world, you also have dangers. And so the second part of this is limiting risks of exposure to external dangers. So it's trying to capture all of this nutrition, all of this hydration, but it's trying to do that in as safe as way as possible, not to endanger the organism. So I know that's kind of super macro, big picture, but I think it's going to help when we think about root causes, because ultimately the GI tract is there to get nutrients. It's trying to make sure that we have the nutrients that we need to continue to thrive and live optimally. So when we break those two things down, remember I said assimilation of nutrients and minimizing the risk to the organism, that's where we can start to slot in some of those methods. So digestion and absorption are the two main methods to assimilate nutrients from our environment. And digestion, we'll get into these a little bit more, but there's enzymatic digestion, there's physical digestion, and there's fermentation. And under absorption, we have this distinction between some things are passively absorbed, meaning it doesn't require any effort for the most part, and other things are brought in actively. There's also this major important facet of surface area maximization, and we see that in a lot of inflammatory conditions this is eroded, so that tremendously impacts absorption capacity. And then motility is another thing that's important to consider with absorption. On the other side, with minimizing risk to the organism, there's this idea of basically what the immune system does. It assesses in surveillance mode, and then it decides whether it needs to tolerate something or whether it needs to become activated. And that's where you have an inflammatory and an immune response. So we're going to kind of lay out this framework so that when you have a patient coming in, you understand which of these areas need to be assessed and worked on. And the truth of the story really lies in the details, because systems medicine, and man, it's complicated. But with anything that's complicated, if you understand where the details lie, then it becomes less and less complicated, and you become more and more efficient as a clinician as well. So I'd like to point out one thing too that I find so interesting, is that the actual lumen of the gut, meaning the GI tract, the inner part of the GI tract, that hollow tube, is not part of us, right? Even though it's inside our body, it is technically the outside world, much like our skin, right? So our skin is a interaction and interface with the outside world, just as the lumen, that hollow tube of the GI tract. So anything that's white on this slide, and this is a histology slide of the GI lining, and the lumen is that part of the white in the upper left. So that's the outside world, right? And this is just like with the skin, this is the interface. So just keep that in the back of your head. It'll start to help you understand and make more sense of maybe why things are structured and laid out the way they are. So here's a little bit of a model that I put together. We started at the top saying, what is the function of the GI tract? It's to assimilate and it's to protect. It's to bring in nutrients and it's to protect us from danger. And it does that through these methods of digestion and absorption on the assimilation side, and protection. We have the microbiome that helps to protect us, and we have the mucosal barrier that helps to protect us. And all of those things can actually impact motility. And this might seem like an odd slide. I actually I got into a big debate with my significant other when I placed motility with such importance here. But it is true that all of those components will affect motility. And why focus on motility? Well, I would argue that IBS, which is our main GI complaint that we see come into the office more than any others, in my opinion, in my experience, is basically a motility problem, right? We're talking about IBS-C, constipation, IBS-D, diarrhea, IBS-M, mixed. This is all motility based. So that's why I'm saying if we're trying to understand root cause of IBS, then we understand what's driving that. So that's these four components here. And so if we clinically focus on the categories of assimilation and protection, then we can start to understand root causes of most of our GI conditions coming in. We have the IBS, which I laid out as being somewhat, in my thinking, as a motility issue. And then we have IBD, inflammatory bowel disease, which is certainly multifactorial, but it is largely a protection issue, because what is IBD? It is an inflammatory response and it is an immune response. So that is on the protection side more so than the digestion and absorption side. One other additional thing to keep in the back of your head is that there's always direct insult to the GI tract from certain things. So I think of alcohol primarily. Alcohol is going to directly impair many different facets to the GI tract, but lower esophageal function, it's going to impact your microbiome. So these direct impacts, other foods and medications can be doing the same thing. And since I mentioned food, we need to think a little bit about diet and maybe reframe how we slot the importance of diet into this model. So I think diet basically has three main impacts to the GI tract. You can have a direct insult on mucosal function, kind of similar to how I mentioned alcohol before. You can have diet impacting the microbiome, and you can have diet leading to an immune response. Okay, so when we're thinking about how what a person's eating is changing something about their GI motility or their GI tract, these are the three main things that diet can do. So when I look at this model again and we think about assimilation and protection, you can also think of this as assimilation is how you digest, and then protection is what you digest. What is the actual thing that came into this system? Okay, so let's start with digestion. Digestion involves breaking down foods into macro and micronutrients, and this is done both enzymatically and mechanically. So mechanically is about how we chew our food. Are we chewing enough? And man, I gotta tell you, ever since I heard 30 chews, maybe it's even more than that, per bite, I said, I'm never going to be doing anything else with my life. I'm just going to be chewing all day. It seems like a lot, but how many of us do not chew our food, and how many of us actually talk to patients about chewing food, right? And this is just kind of a funny little aside. When I went to find some research around the impact of chewing and mastication on overall GI health, I found some interesting studies. So the first one here is actually a study showing that salivary functions in mastication, taste, and textural perception, swallowing, and basically asserts that yes, chewing is good for you because it activates all these different salivary enzymes, and it actually helps to do the pre-digesting, break down the food. But then, like all research, I found this counter argument that said actually swallowing food without chewing is a simple way to reduce postprandial glycemia. And I was like, what? Like they're literally saying don't swallow or don't chew your food, just swallow it because it's going to keep your blood sugar low. And so I kind of was able to, like we do, not keep these in silos, integrate them. What they're saying is like, if you're eating something that's high in sugar that maybe you shouldn't be eating, especially if you're insulin resistant or diabetic, then if you don't chew it, you're not going to get as much sugar in the system. So I would reframe this as, if you're chewing something that is high in nutrition or you're eating something that's good for you, you should probably chew it as much as possible. Maybe if you're eating something you shouldn't be eating, have at it, right? So I just thought that was kind of funny. So how do we improve digestion without having to chew or chewing or just improving it in general? So to improve digestion, there's three major components that go into the actual process of breaking things apart and breaking them down. pH is essentially your stomach acid, there's enzymes, and then there's bile. And all of these things help to improve digestion. But we can't always do this ourselves, which means we have friends, the microbiome, and things that we actually can't digest, they're in part there to help ferment and break them down further. So that's a little bit of that symbiotic relationship that we have with them. So let's talk a little bit about how to have some tools around some of these digestion improvement elements. Gastric pH is critical in breaking down protein into polypeptides. That's one of the main things of pH. It's essentially going to help break apart those bonds in protein. But don't forget that digestive enzymes, whether that's enzymes that help break down fats, sugars, protein, those also have a window of a pH that they operate maximally at. So adjustments, alterations in pH not only inhibits your ability to break down things and proteins and things like that just because of the acidity, but they also will impact how well their enzymes are functioning. So that's important to keep in mind, that pH has kind of a two-tiered element to it. So if the patient doesn't have appropriate pH, like I mentioned, the enzymes won't function as well. And these are things like protease and lipase. Here we have a marker that we'll get into a little bit later called products of protein breakdown, which is a pretty good indicator of how well somebody's breaking down protein. We also have another marker for a direct method of understanding pancreatic enzyme production called pancreatic elastase. But also, eating hygiene is huge and with regard to pH and enzyme function. And what do I mean by eating hygiene is not eating on the go like this, right? It's eating in a parasympathetic state, in a calm, relaxed, restful state, is very important when it comes to making sure we have adequate pH and enzyme functioning. So just a little plug for thinking a little bit more mindfully, or some people call it mindful eating as well, I believe. Okay, what are some causes of hypochlorhydria behind eating on the run? Zinc deficiency is a big cause of hypochlorhydria, and zinc deficiency is not uncommon in today's day and age. So zinc is one thing to keep in mind with respect to low HCl. B vitamin deficiency can also lead to hypochlorhydria. H. pylori certainly, from an infectious standpoint. Stress, as I mentioned, and also just to keep in mind, naturally over the course of aging, we do have a decreased production of pH and stomach acid. So between 25 to 40% of achlorhydria after 50, after 50 years of age, between 25 and 40% of people have achlorhydria. So that's from the articles that I cited below there. So that's fascinating. 25 to 40%. It makes you wonder about all these patients presenting with GI symptoms. How do we improve it? How do we fix it? Well, if zinc and B vitamins were part of the problem, then they can be part of the solution, right? We can certainly evaluate zinc and B vitamins with maybe a micronutrient assessment or things of that nature to make sure that we really we should be supporting that. Eating behaviors that stimulate HCl, like I mentioned, the mindful eating, that eating hygiene. And then we can get into more direct support like betaine HCl, actually taking HCl. And, we'll probably talk a little bit later about an HCl challenge. But if you're not familiar with what that is, you could probably go and research that or consult some of your fellow clinicians. Gentian is, I'm a naturopath, so I tend to like some herbal medicines from time to time. And gentian is really great at supporting pH and enzyme release as well. So gentian is a very bitter herb. It's meant to be taken in a liquid form because it's actually mostly the stimulation of the bitter taste on the tongue that sends a signal to the body to produce more pH, to produce more HCl, as well as release some of your enzymes. So if you're doing something like gentian, works great. It's also very good for people who have a low appetite, because it actually stimulates kind of the pre-digestive system. So maybe that's new to you, give it a try. Maybe just pick some up and try it on yourself to see exactly how bitter it is before you give it to your patients. I normally do about 5 drops in 4 ounces of water, something like that, and that's all you need. So apple cider vinegar, there's not a lot of literature to support. I have found that apple cider vinegar in my empiric clinical practice, it does tend to work supporting people's digestion. However, it's a little counterintuitive because apple cider vinegar is actually not as acidic as somebody's natural stomach pH. So I don't have a mechanism for maybe why that could be helping to increase HCl production, but I have seen some benefit in using it. All right, so that's the pH side. What about all these enzymes, right? We have enzymes for breaking down protein called proteases, lipases for breaking down fat, amylases for breaking down sugar. Well, first thing we can do is we can evaluate, right? Does the patient have low pancreatic elastase on their GI test? And that's a pretty darn good indicator for pancreatic insufficiency. Some other indicators are high levels of protein products, meaning proteins not being digested and absorbed very well, so it's showing up in the stool. High stool fats, same idea. It's not being digested, so we're seeing it on the back end. And then there's something more invasive, a radioactively labeled CMTG breath test. Not a big fan of this one for several reasons, but I don't think we need that when we have really great tools easily accessible, like on this GIFX report. Pancreatic enzyme replacement. It's certainly indicated when somebody has low pancreatic elastase levels, they've got pancreatic insufficiency. You want to make sure the patient is getting as much nutrition out of the food that they're eating and they're not having maldigestion. So keep in mind, it's a bit of a band-aid, right? It's not exactly fixing the root cause that created the pancreatic insufficiency. It's helping them in the meantime, while hopefully you are getting to that root cause. So with that, what are some root causes? So here's some direct causes of pancreatic insufficiency or EPI. We've got cystic fibrosis, pancreatitis, pancreatic resection, gallstones, all those sort of pathologies, more dramatic pathologies. But there's other things that are more subtle that are associated with it as well. So inflammatory bowel disease, not subtle, celiac disease, not subtle, but these can be associated with pancreatic insufficiency where maybe you wouldn't think it. So another thing, excessive alcohol consumption. SIBO actually has an indirect way to create pancreatic insufficiency or subclinical or maybe mild pancreatic insufficiency. Smoking, obesity, vegan, vegetarian diets. That's kind of interesting. So the body typically responds to what a patient's eating. And so with vegan vegetarian diets, it tends to lower the production of some of the proteases because there's not as much need for, strong protein breakdown. So that might not necessarily be a pancreatic insufficiency in the classic way that we think it. It could just be a modulation of the system to accommodate the diet. So a little bit of a caveat with that one. Diabetes and infectious enteritis as well have all been associated with this type of pancreatic insufficiency. Keep in mind, everything's a sliding scale, right? There's shades of pancreatitis. It's not just like you have pancreatitis or you don't. You can have low levels of pancreatic impact just by things like mild insulin resistance, alcohol, smoking, some mild inflammation. This pancreas is strongly susceptible to oxidative stress. So keep that in mind that if you see a lower pancreatic elastase in a patient and you can't really figure out what's going on, think about even that list and like could some of these things on this list be minor, a minor SIBO or maybe a little bit more alcohol than they're reporting to me, those sort of things. So one interesting thing about the SIBO that I just mentioned in pancreatitis and pancreatic insufficiency is that SIBO creates an inflammation and damages the mucosa of the GI tract, which actually through a feedback mechanism leads to less cholecystokinin, which reduces that pancreatic stimulation. And so there is a well-known mechanism for how SIBO, bacterial overgrowth, more of a microbiome issue, can impact pancreatic function and cause maldigestion. So keep that in mind. I'll leave these reference slides up for just a minute if you want to pause and review them, but just to show that these things have a good amount of backing. Moving on to bile, we talked about pH, we talked about enzymes. What about bile? Bile has some sneaky roles. So bile does activate pancreatic lipase to break down fat. So it's not just for absorption. It's not for just bringing fats into the system. It actually does activate enzymes. And also to a certain extent, it's antimicrobial. So if we're thinking about a bacterial overgrowth picture, think about bile too, because like I said, it helps to regulate the bacteria and especially the small intestine. It's also critical in excreting bilirubin and toxins and things of that nature too. So I'm not going to go into all the details, but a few things to note. Bile is secreted in direct response to fat in the meal and in the diet overall. So if you're doing anything like you're trying to get somebody to take more fish oil, you want to have them supplement that with some type of fatty meal because it's not going to get into the system as well if there's no bile around. Bile is also secreted in response to cholecystokinin. Okay, so that kind of goes back a little bit to that SIBO mechanism that reduces cholecystokinin is also going to impact fat absorption. So you start to see where these things are connected. And the last thing is that 95% of bile salts are supposed to be reabsorbed. And if they're not, there is a lot of issues that can arise from that. There's a condition, bile acid malabsorption, and this is really thought to be significantly underdiagnosed. I think this is going to be something that we're going to find more and more is underpinning a lot of our IBS conditions. There's one study that's have cited here that said, could represent at least 30 to 50% of all IBS-D cases. So that's pretty significant. The mechanisms of this bile acid malabsorption is basically you have an increased secretion of sodium to water in the gut lumen. This stimulates peristalsis, right? So you have a faster movement, and then you have increased mucus secretion, which then also damages the intestinal mucosa, further impacting cholecystokinin. So it's a downward spiral because you have bile causing damage, and then you also have damage leading to lower production of bile. So there's a little bit of a feedback there. Some major causes of bile acid malabsorption, there's 3 different types. One is Crohn's or ileal resection. The second is idiopathic, which basically means we don't know. And then the third is having your gallbladder removed, celiac disease, SIBO, pancreatic insufficiency. So it's actually more of this type 2 bile acid malabsorption that I think we should be focusing on. And stimulating bile production, but then also repairing the mucosa are going to be the main things we want to do with respect to correcting bile acid malabsorption. And you can do that by all the things that we've talked about before and we'll talk about in the next several weeks. Okay, so on the digestive front, we have the pH, the enzymes, the bile that we've talked about. We talked about chewing, and all of these things are things that you can assess on the GI-FX test, because we've got markers for absorption, we've got markers for enzyme function, we've got markers for pore breakdown. We actually have, some indications of even bile with respect to phospholipids. Bile is high in phospholipids, so sometimes we'll see that really, really elevated, maybe cholesterol as well to a certain extent. Now, moving on to the absorption side of things, we have the passive and active aspect. We have surface area motility. I'm not going to spend a ton of time on this, but basically we have a lot to learn on the absorption front. The interactions between passive and active absorption, there's incredible dynamics that are at play here, and there's a lot of personal variability from a genomic perspective. A lot of SNPs can play a role in how well somebody maybe has a transporter that is able to bring in different proteins and amino acids, things of that nature. So we have a ton to learn on that area. Surface area, keep in mind, I think the main clinical point here is that the amount of inflammation and damage basically is going to play a big time role in the blunting of your microvilli, which lowers your surface area, lowers your opportunity for absorption. So if there's inflammation, there's likely some degree of damage occurring, and that is playing a role on your surface area. And that's correctable, that's fixable, because as we know, the GI tract is very good at regenerating itself. So fix the inflammation and you're going to improve surface area. Motility is a vicious cycle. Poor absorption causes motility problems, and then it creates motility problems back to that bile acid malabsorption. So motility is basically what we're trying to fix when it comes to IBS. So this is your outcome, but it also plays a role in how well you absorb, because if somebody's having diarrhea, they're not absorbing very well. One way to address motility clinically, we talk about fluid dynamics, and fiber is playing a big time role in this. And I think you could have a whole boot camp probably on just when to use soluble and insoluble fiber and how to use fiber. There's a lot of great resources out there for that, so I'm not going to spend a ton of time there. But keep in mind, when you're reaching for fiber or you're recommending fiber, try to really specify what type of fiber might be best for this type of patient. I tend to find that people with constipation do a lot better with soluble fiber, and people with diarrhea tend to do better with insoluble fiber. And so you can think a little bit about that. The migrating motor complex is another key area of motility, and serotonin is actually a major regulator in the migrating motor complex. So serotonin plays a big time role in motility, and it's gut produced serotonin, not brain produced serotonin. And so there's a lot of different mechanisms we can try to alter, but SIBO actually may have a tremendous impact, or maybe methane production has an impact on overall serotonin levels. So lots to learn there as well. So it might often look complicated, but even everything that I just stated all goes back to understand the model, right? Understand it's about how you digest, what you digest, and where is this patient having an issue? Are they having a digestive issue, or are they having an absorption issue? And then walk through those things that we just listed. So moving over to the microbiome side of things, we're getting into this idea of it's about what you're digesting, not how you're digesting. And we always think about, like, we're learning so much about the microbiome these days. What actually is driving what, right? Is the microbiome causing so many of these diseases? Are the diseases shifting the microbiome? Which is driving which? Is it this much of an interaction? There's a lot of questions there. And this is an example. We used to have this chart where it said, hey, in these different clinical conditions, here's the microbiome shifts that you'll see. And a lot of docs would say, oh, look, you've got this high level, you must have all these different diseases. And it's not exactly like that. It's there's an association, right? The correlation is not causation. So what's the real root cause? What role is the microbiome playing? This is the way that I tend to think of it. So we have these inputs like diet, your mood, your sleep, your exercise, all these lifestyle things, right? And depending on those lifestyle things, those are going to create a microbiome pattern within reason, or they're going to shift the microbiome depending on what you change in those areas. And that shift then changes what the microbiome does. And we'll get into this a little bit more, but the microbiome is basically there to produce a lot of different things like metabolites and gases. And we mentioned serotonin, other neurotransmitters, vitamins. So it's a big picture, but keep that in mind, right? When the microbiome kind of sits right in the middle there of it's impacted on one side, and then that impact creates changes in function. When we're assessing the microbiome on the GI effects test, we break it out into 3 different areas. We break it into bacterial, fungal, and parasitic. And so that's under this area of infection, right? You can have different types of infection, or maybe it's not just an infection like a frank pathogen, a salmonella or something like that, but maybe it's a dysbiosis, which is more of an imbalance in the commensal bacteria. And then lastly, not just who's there, who is in the microbiome, but what is the microbiome producing? And that's almost as important. We'll talk a little bit for a moment on that later. So they are producing things like short chain fatty acids, which we'll get into. They're producing different gases, like I said. Some of them might be producing endotoxins, which are affecting the overall GI tract. So when I think of the microbiome, I think of kind of 2 root causes. Who's there and what are they doing? And when it comes to who's there, we can think of there's pathogens. Those are our parasites and our salmonellas, maybe our yeast pathogens. There's pathobionts, which mean opportunists, right? Things that maybe aren't causing a problem, but maybe at a high level, they're causing a problem, or maybe that particular strain produces an endotoxin in some circumstances. Those are things that can be problematic, but aren't always. And then there's dysbiosis, which is really not even those 2 things. It's what is the subtle shift in the players in the microbiome. And so that's one root cause. The other is, what are they doing? Microbial metabolites are what they're doing. They're producing lots of different things. And so we need to evaluate that as well. There's lots of different methods we can use to assess the microbiome. There's a bacterial culture, which has the pros of allowing us to actually see how viable an organism is. If you're just measuring the DNA, you know that at some point it was there, but that doesn't give you any information on whether that organism was actually alive or not. So culture is great because it tells you about viability. There's 16S PCR, which can be qPCR or what's called endpoint PCR. This is great from a quantitative perspective, and most of what we're using this for is actually data analysis. This is where it gets into the dysbiosis, the balance of bacteria, and is there a subtle shift that's not, directly pathological, but is there something to be told about how there's an imbalance in these bacteria? And then lastly, We're moving from kind of newer and newer methods. We start with culture, we move on to 16S DNA, and then we move on to metagenomics, which is really, at the end of the day, we call this whole genome or shotgun sequencing. And this is not just looking to say how many of lactobacillus is in this person's GI tract, but this is to say I can identify almost the entire microbiome. We can assess the genes that encode for metabolite production, right? So we know this organism has this gene for making butyrate. And so we have a direct kind of assessment for the potential to create butyrate. There's some things to know about whole genome sequencing when it comes to accuracy. And the first one is that the depth of sequencing is something that's hugely important. You can have a very superficial layer of sequencing that will probably give you some inaccuracies here and there, or you can go really, really deep, meaning you're reading over and over and over again to get really superb accuracy. So that's important. And then you also have to have a really great library to be able to identify the organisms that you're finding. So those are very, very important. Things that we can actually glean from whole genome sequencing that we might not be able to get as accurately elsewhere is things like the diversity of the microbiome. We look at that with respect to what's called the Shannon diversity. We have the overall balance of the different phylum, and you can sometimes see what we call like a donut chart here to tell you the proportions of different types of bacteria. And you can also just as easily find pathogenic or opportunistic organisms. So that is really, really important when it comes to microbiome assessment. And actually, you can find that in our test called the microbiomics. That's a whole genome sequencing test that's available as an add-on to the GIFX or as a standalone. All right, so what's the clinical relevance about a microbiome profile? What do we care about? What are we really looking for? Well, first, we're looking for pathogenic organisms that cause direct harm to the GI tract. And they usually do this in the form of secreting endotoxins that create damage. That can help us to determine if we need to eradicate. And fecal secretory IgA is one marker on the GIFX test that tells you whether there's some issue at the GI lining, whether there's some perturbation. And so keep that in mind, keep that in your back pocket. We'll talk more about IgA a little bit later. So that's kind of the pathogen or pathobions part, right? They're causing direct harm. What about this dysbiosis part? And I'm going to get a little bit on my high horse for a second around dysbiosis because I feel like this term tends to be used fairly loosely. And so what is dysbiosis? Well, some people might say it's an alteration of the microbiome from somebody's baseline, right? One day you're like this, or maybe for 18 years of your life, you're like this. And then all of a sudden it's shifted and it's different from yourself or what your optimal was. Another person might say it's an alteration of the microbiome compared to healthy individuals. And we do have a little bit of an assessment that way as well, because we have a marker called the commensal balance graphic or commensal balance score, where we did just that. We took all these different clinical conditions and we compared people who were basically healthy as compared to not having clinical conditions, and then people who had one or more of these clinical conditions. We looked at their microbiomes and we were able to deduce a pattern that is predictive of whether somebody's likely to fall into the healthy category or the unhealthy category. Another way to define dysbiosis is related to, is there some type of microbiome deficiency because the patient just took antibiotics, or is there an overgrowth for various reasons? You might also think about whether dysbiosis is having like a Candida albicans or having a Klebsiella at a high level. Do you have true pathogens or maybe opportunistic organisms that can cause problems? So that's one way I think to define dysbiosis. But if we go back and we think about this model, one of the things I'm thinking about is, well, dysbiosis, how do we even know it's there? What's it doing? And what's the main problem? And I would say that the real importance of dysbiosis is not necessarily in which bacteria are there, but it's about what those bacteria are doing, right? Because one of the major roles of those bacteria is to produce things that are beneficial for us. So if we are able to look at not just who's there, but what they're doing, It's all about what metabolites are being created. This is what leads to motility issues, and this is what leads to IBS complaints and even other inflammatory conditions. So to me, it almost kind of begs the question of, is dysbiosis a real thing that we should be talking about or thinking about? Or if we just cut out the middleman and think, what's actually being produced? That's really the clinically important question. So I think a little bit more to talk about there, but when we refine this idea of dysbiosis, it's not specific to any bacteria or any genus, and it doesn't create any consistent pattern of symptoms just by having dysbiosis. We have to think about types and what are things that are happening? What are these functions? So if we reclassify dysbiosis into these functional categories, like on the GI effects test, you'll see there's these dysbiosis patterns, right? We have an inflammatory pattern. We saw that there was a shift in all of these bacteria that tends to lead to more inflammation, or maybe immune suppression. We have a shift a different way that leads to more methane production, which can suppress your immune system. So we're really trying to move away from this kind of consensus gathering, raise your hand bacteria if you're in the GI tract, to think of, okay, what is the overall thing doing, and what patterns might we slot this into? What about SIBO? We talk a lot about SIBO. So causes of SIBO, we mentioned before, low pH, low enzyme or bile secretion. We have impacts to the migrating motor complex, which cause motility problems. And then maybe even IgA deficiency could be playing a role in SIBO as well. But underneath that, some of the root causes, right? Just match those up. Low stomach acid, hypochlorhydria, pancreatic insufficiency, motility issues, IgA deficiency. So when I think about SIBO, I actually don't think of it as a separate thing from all the stuff we just talked about, right? On the digestive side, you have pH, enzymes, and bile. We've got motility, we've got IgA. These are all part of the system. So if you're correcting these root causes, you're also helping to correct SIBO in a patient. So keep in mind, it's all together, right? It's all grouped together, and the test is supposed to help you get there. We talk a lot about microbiome diversity as well. I'm not going to spend a ton of time on this, but just know that diversity is what we call mostly alpha diversity is the main clinically relevant diversity marker. And that takes into account, what we call richness and evenness, so is there not just a dominance of one bacteria or a couple, is there evenness? And then how many different types of bacteria are what go into that score? But as I mentioned before, instead of obsessing about who's there, we can start to think about what they're doing as well. And what they're doing is producing these metabolites. And we'll get into a lot of these a little bit later, but the short chain fatty acids are hugely important. These different gases are very, very important. And also keep in mind, the microbiome produces some vitamins as well, which is kind of interesting. Here's a list of some of the things that are evaluated on our microbiomics test. These are also very important markers to be looking at. Hexa-LPS is an inflammatory marker. I'm not going to go through this whole list, but it's here for you to reference as well. And just keep in mind, when we're looking at these things from a whole genome sequencing standpoint, we're looking at the measure of DNA within a microbe that encodes for production of things. So inside that bacteria, there's DNA that says, hey, make butyrate. And so once we understand which bacteria do what, then we can make some assumptions about what they are making. It's not the same thing as when you're looking at your GI effects test. We're actually directly measuring butyrate production. Right. So there is a little bit of a different assessment when you're making an inference from the microbiome and what their genes are as compared to just measuring directly that thing. So I'll leave that there for the sake of not getting too complicated about it. One other thing I think is just fascinating is that the microbiome is so adaptable that one of these genes, the abundance of one of these genes in the microbiome is generally a good indication of what the microbiome is doing in that moment. So even though if you're looking at the potential for the microbiome to produce something, or let's say break down protein, you're going to find more of that bacteria if you're eating a lot of protein. So And this is just the example I was saying, a high protein diet, what happens? Well, you're eating more protein, the microbiome shifts in a way that favors those bacteria that use protein as a fuel source. So you're going to get more of that, which is going to increase your finding on the report for protein degradation. So that's kind of an interesting thing as well. Just another example that I think we've belabored that point a bit. So that's the microbiome front. Remember, think of dysbiosis patterns and then guys who are there who shouldn't be there. That's kind of the two roots underneath clinical evaluation of the microbiome. Lastly, we have this mucosal barrier. And man, this is amazing. This is how that mucosal barrier interacts with the external world. And I think of it almost like I mentioned before, think of your skin, right? That interface with the external world has to be kept in check at such a high degree of precision. And this is where the immune system comes in, and it's responsible for doing just that. It's making sure what you ate is okay. And if it's not, if there's pathogens, if there's toxins, poisons, it's got to react. And it does this through two facets. It assesses, and then it decides whether to tolerate or to become active. And mucosal assessment is so crazy. You've got these little dendritic cells that are basically responsible for keeping an eye on everything that's going and passing through your GI tract. And they are just incredible. I love studying the dendritic cells. There's so much more to learn there. But they basically serve as the watchdogs. They're constantly sampling the microbiome population. They're sampling what foods you eat. And from a clinical perspective, there's actually some recent evidence suggesting that vitamin A is very important in proper functioning for mucosal assessment and dendritic cells. So probably haven't heard that one. It's maybe something to keep in your back pocket as well. When it comes to tolerance, primarily tolerance is developed early in childhood, and continued tolerance is critical to make sure that we're not overreacting to things that we should be considering as safe. And the literature is really starting to suggest that immune tolerance loss in the GI tract is potentially due to increased intestinal permeability and inflammation. So think about that. The more active or reactive our immune tract is in the GI system is basically in part due to problems with permeability or leaky gut and inflammatory processes. So let's just spend a minute on intestinal permeability, since it's so important in the immune function. Things that increase permeability are a reduced butyrate production. Butyrate's a short-chain fatty acid that we'll go into. We measure it on the GI effects test. Increased serotonin production is a problem with permeability. Impaired mucus production, pathogens, secreting their toxins will cause permeability problems. Gluten all by itself can cause permeability issues. And then diet and strenuous exercise are also things that impact permeability. But going back to the chicken and the egg question too, what actually comes first? Is it the leaky gut, the permeability, or is it the inflammation? And I think this is something we have yet to unwind, because what we often find, if you're doing something like an IgG food sensitivity test, that the things that a person is commonly reactive to are actually the things that they're eating. And if that's what you're finding, or if you're finding this thing is lit up like a Christmas tree, then that's a permeability issue, because as there's permeability, there's leakage of whatever proteins, peptides from the food that a patient's eating into the bloodstream. Now the system has to react, because it's not supposed to be there. You're not supposed to have food proteins and things of this nature floating around, or even just below in the next layer of the GI lining. So keep in mind that food sensitivities and permeability are intricately connected. We can also look at permeability through something called the lactulose mannitol test, which is kind of the gold standard for looking for intestinal permeability. And then plasma L-citrulline. I actually found a paper, interestingly, L-citrulline is sort of an amino acid-like compound, kind of like a protein breakdown component. And levels of plasma citrulline might actually be a signal for intestinal permeability. I don't think we can quite use it yet as diagnostic, but that it is interesting that there's some evidence growing here. How do we improve barrier function? So we have this sort of T regulatory and tolerance support, right? That part of that making sure that everything is coming in and everything is safe, all that assessment that's happening. Like I said, vitamin A might be something to think about. And I also think about supplemental IgG, like our bovine immunoglobulins, like that's a really great way to improve barrier function as well. When it comes to supporting the mucus layer, man, aloe, I think it's fantastic. Slippery elm, Akkermansia might play a big role there. This is a new supplement that's out. You can actually take Akkermansia directly. When it comes to aloe, I tend to think of using the actual liquid form of aloe. And so that's the main way. I think powdered aloe probably isn't as effective as doing a direct aloe supplement. And then supporting this sort of activation aspect is you're going to want to use antimicrobials if there's a dramatic infection going on, or maybe even something that's a potential pathogen. And then you want to support inflammation and mucosal repair after that has occurred. So quercetin, fiber, and L-glutamine are going to help with mitigating inflammation and repair following an infection. So those are the things that you think about it from improvement of barrier problems. So we talked about mucosal barrier, we've talked about digestion, we've talked about absorption, microbiome. I'm hoping that this helps you to kind of really kind of rethink how to come across and how to use this GI effects test and understand the patient that's sitting in front of you and what needs to be worked on. Because at the end of the day, the GI tract's role in the system, again, is to maximize the assimilation of nutrition at highest efficiency and also limit the risk to exposure from external dangers. And so if you just keep that in mind, then it's really going to help you sort through some of these complex patients that are going to come into your office. Because, man, I don't know about you, but a lot of the patients that we see in root cause medicine have a long list, a long history, and they can be very, very complicated. And the more we can simplify that, the better. So hopefully that has been helpful. I'm going to turn it over to Dr. Stephen Goldman for his side of the presentation, walking through the report in more detail. And I can't wait to see you all on Wednesday and make sure and have some questions ready to go. I think we're going to be getting some questions ahead of time as well. So yeah, this is going to be fun and can't wait for more of it.
Hi, everyone. This is Steve Goldman at Genova Diagnostics. Today, we're going to be talking about the GI Effects Comprehensive Report. We're just going to do an overview to get a sense of the various sections of the test and the meaning of the test, so it has greater clinical utility. Here I am, Stephen L. Goldman, DC, and here is the test. This is the front page. We'll talk about all of these individually, but just to give you a sense of the front page with its ratings, pages 2 and 3, which are going to be about statistical analysis, most specifically analysis of the 24 commensal bacteria through DNA. We also have the digestion, absorption, inflammation, and gut microbiome section, DIG acronym. And here is at page 5, the listing of the 24 commensal bacteria from DNA. And as I said, pages 2 and 3 are really about looking for patterns so as to get better clinical utility of these findings. Page 6 is all about culture strength, viability of various bacteria and yeast, and also indicating whether or not they're potentially pathogenic, and then providing sensitivities. And a microscopic parasitology, looking under the microscope, we can really widen what we can see as far as parasites, although we also on page 8 here have the various parasitology findings, the 6 through DNA findings and some added tests. These are add-ons as well. And then the sensitivities, because when you have culture, when you're evaluating a living organism, you can see what it's susceptible to. And as a result, you can design a protocol very specific to what we find on the test for your patient, as well as for the yeast findings if they are potentially pathogenic. So a lot to look at. So let's begin on this front page and our functional imbalance scores. The functional imbalance score is a great way of getting a sense of the overall findings and personalizing the protocol. So if you look at these various findings, you'll see green, gray. So green would be 2 or less. In green, a low need for support. And let me go back to that. The gray would be the metabolic imbalance that you see here, which would be optional. The 4 here in yellow would be a moderate need. Red would be a high need. So again, green, minimal need, gray optional, yellow more moderate need, and red high. And you might look at this and say, well, how is it that we ended up with a 7, a high need around infection? And the answer is the various findings here. These are the biomarkers where you see green, they're in the reference range. Yellow, they're in the range, either high or low. Red would be outside the reference range. So this red 7 is really coming from these two, the high red, the moderately high yellow within the reference range. It's also a great way to compare findings from test to test to see exactly the rating of the patient in each category and the changes that occurred that caused that rating to change. These are the 24 commensals, page 5. And it's difficult sometimes to really analyze what is the meaning. Commensal is Latin, and it means expected at the table. You expect commensal bacteria. They're not pathogenic by their very nature. Usually it's imbalance that makes that the issue. And that's why we make a really strong effort, and I think you'll see that here, to provide you with data to look for patterns that are very informative. Because clinicians struggle with this, and there are limitations. Different labs, different studies utilize different methodologies of DNA. And so you see changes in the different publications in terms of what they conclude. So we provide, with such a long history of testing, we can look at patterns that can be really informative, and it's a great advantage of the test. And when I speak to those patterns, these are pages 2 and 3, and they're really all about patterns. So the pattern of commensal abundance, both total abundance versus each individual phylum, comparing your patient to the healthy cohort in both instances. And we'll look at that some more. Patterns, various patterns that emerge, these dysbiosis patterns, the IAD, inflammation-associated dysbiosis score, the methane dysbiosis score based on in-house Genova studies. And then finally, balance. Where does your patient stand based on these findings statistically? Healthy, less than healthy, unhealthy individuals. So all of this is data-driven statistical analysis to get a better feeling as to what these findings mean. So let's look at the commensal abundance. You see here at the top, and a shift to the right means the patient has more commensal bacteria. So where it has healthy cohort, 100%, this represents your patient. If it drop lines right over 100%, they have the same population, but it could move to the right, in which case you're thinking about potential microbiome overgrowth. Now, it can also be your patient is very aggressively on pro and prebiotics and fermented foods, but also SIBO, for example, would be an example where we often see overgrowth. So it may be indicative of something like a SIBO overgrowth, maybe supplementation, but a shift to the left, -10, -20, lower than the healthy cohort, would indicate that perhaps this patient has been on antibiotics. Maybe they've been treated for something that led to antibiotic therapy and really depleted the microbiome. And as a result, it may be more about rebuilding and reinoculating than giving a some sort of botanical antimicrobial or potentially a prescriptive to kill stuff when reinoculation really becomes the issue at hand. So these are the dysbiosis patterns I mentioned earlier. These are the two in-house studies that were done by Genova. And so I'm going to go back there. The IAD score was a study of over 8,000 GI effects. And those 8,000s had one thing in common. Each of them had an inflammatory finding. And when there was an inflammatory finding, the question posed was, are there patterns that emerge on page 5 for those 24 commensals when there is inflammation? And there are certain patterns, very often low commensals because there's inflammation. Here we have a score of 29. Anything to the left of 60 is considered low in the green. But if we get past 60, higher and higher, that would be a high IAD score, and we would expect statistically to see some of the various changes in the patterns or the emergence of patterns on page 5. So the inflammation-associated dysbiosis score, it's a pattern associated with inflammation that we see play out on this page of commensal bacteria. And it's correlated with CalPro, eosinophil protein X, secretory IgA. It's an algorithm. And then the second study was the methane dysbiosis score. The methane dysbiosis score is really kind of fascinating. It was over 1,700 patients that did the GI effects, but also ran a SIBO test with Genova that was positive for methane. And as you may be aware, in methane positive SIBO, SIBO methane, SIBO constipation, now termed IMO, intestinal methanogen overgrowth, we see slow transit time. We see gas after meals. We see constipation. So the question that was posed was a little broader here. Rather than how does this affect the commensal page patterns, the question was across the board on a GI effects. Were there patterns that emerged? And there were. So it's a specific dysbiosis pattern associated with methane. It correlates with methane production on Genova's SIBO tests. It's based on the commensal bacterial profile and stool biomarkers throughout the GI effects. And we do have an algorithm to get a sense of whether or not there's higher methane. So this is what it looks like on the page, but you can see anything to the left of 5 is low. One would not expect the patterns to emerge. But as you get higher to 6, 7, 8, 9, you get to the yellow around 9, 10, the higher you get, the more you expect to see the individual test align with the patterns of the study of 8,000 tests. So here again, we have an IAD score of 29, a methane score of 1. They're both low. As a result, that will place the patient with the x-axis, the IAD score of 29, and the methane score at 1 in zone 1. And for zone 1, as you can see right here, the commensal profile in this zone does not align with profiles associated with intestinal inflammation or immunosuppression. If inflammatory biomarkers are present, other causes need to be excluded, such as infection, food allergy, or more serious pathology. Now, I know for me, I'm wondering, what if you did have a high methane score? What if you're looking at this test and the patient did have a positive SIBO or does have high methane? The patterns that I was talking about are here, the zone 2. And it says here it's associated with impaired intestinal barrier function, low secretory IgA, low EPX, thus the immune suppression methane score. Patients in the zone have higher rates of opportunistic infections, blastocystis, dientamoeba, as well as high fecal fats, and commensal abundance is higher in this group. I would add another thing that we often see, which is on page 5, is the Methanobrevibacter smithii is high, and that's a major methane producer. So if you're wondering, what are the patterns that sometimes come out on these methane positive scores? Zone 2 is like a laundry list of that information. Now, the commensal balance is a breakdown: green representing healthy individuals, yellow some healthy, some unhealthy, red predominantly unhealthy. And statistically, there are 2 data data, I said it with an ER, but I meant to say data points for the reference variance and the healthy pattern continuum that place this patient in the green healthier group statistically. So the reference variance score, which by the way, is mentioned on the front page under dysbiosis as one of the biomarkers, is a 0 to 12 scoring based on the 24 commensals on page 5. And basically, if you have a lot of commensals that measure either at the low end or high end of the reference range, that is statistically more associated with a patient that has poor health overview. And so that's what the reference variance score is telling us. The higher the score towards 12, the more you're seeing the measurement in the edges, the high and low edges of the reference ranges. Whereas in healthier individuals, it tends to be more of a middle ground. As far as the healthy pattern, and let me just do my animation. There it is. So this patient has a U at 2, a pretty low reference variance score, which tells us that they're not really measured on the edges a lot. And then, of course, the healthy pattern continuum is another calculation. This is a 0 to 10 scoring. We took a targeted few of the commensals, ran them through an algorithm where it was observed the higher the score from 0 to 10, the more likely to be in that healthy green distribution. And you can see you could be at 0, but still be in the green. But look how narrow the chances are. As you get higher and higher, this is how the distribution played out for healthy individuals. So between a reference variance score of 2 and a healthy pattern continuum of 10, this patient statistically is more in line with healthier individuals. And then finally, in terms of the data analysis, the relative commensal abundance, remember the first thing we did was compare the sum of all the bacteria on page 5 against your patient. And that was the overall commensal abundance. Here we're going to be more specific and break it down. So a healthy cohort, this plumb line tells you each individual phylum and how it compares to the healthy cohort. So if the color-coded bar extends all the way right up against this drop line, this plumb line, that would tell you that the population is exactly the same between the healthy cohort in that phylum and your patient. To the right, like this Firmicutes, is almost 25% higher. So it's a great way of breaking it down more specifically. The value here, I think, is also from the fact that you have this static text. And so it gives you some interesting information. For example, the Bacteroidetes, a lot of these are from animal-based diets. So when I start to see a lower Bacteroidetes, that may be the case. Whereas the Prevotella in this particular phylum is more plant-based. So if just a Prevotella is high or low, that's a very informative finding. Whereas the Firmicutes, most species are responsive to plant-based diets. So it's wonderful information and a great way of breaking down each phylum in terms of what it can tell us about page 5 and the 24 commensals. Now, when we get to the next section, page 4, past the data analysis, now we're looking at that DIG acronym. And you see the logo on the left there is actually an active thing. So D is for digestion and absorption, and that's our maldigestion rating. The inflammation and immunology from the DIG acronym. And you see that we do have inflammation in the logo. And then the gastrointestinal microbiome. So our DIG, digestion, absorption, inflammation, immunology, and gastrointestinal microbiome. So let's have a look at each of these sections in more detail. For the digestion and absorption, we have pancreatic elastase 1. Pancreatic elastase 1, here you see the graphic, a little different from the ones beneath it. It's based on medical decision points, basically. Pancreatic elastase 1 is a very good indicator of pancreatic enzyme secretion. 100 or less, a high need. 200, lower to 100, yellow, moderate need. Greater than 200, you're in the green, and that's a good thing. I tend to think 400 or greater is really where I want to be. This greater than 500 is the highest score, so that's a great finding for pancreatic enzyme secretion. I'm going to go through these as I would on the phone, and then on the next page, you don't have to write a lot of notes. There'll be slides here that go through what I just said, really. A digestive enzyme secreted by the pancreas, that's pancreatic elastase 1. Here's some interesting information. Pancreatic elastase 1 is not affected by transit time, although profuse watery stool samples may falsely lower due to dilution. So it's a great advantage. If you have a patient that has a slow or fast transit time, it will not impact the level of pancreatic elastase 1 measured, and neither will digestive enzyme supplementation. So if you have a pancreatic elastase 1 that's low, and then you give digestive enzymes and you retest, and the pancreatic elastase 1 is still low, that's not a failing of the digestive enzyme clinically. It might have done a great job, but the only way pancreatic elastase itself goes up is if they produce more of it. It is in correlation with the gold standard secretin cerulean test. Low levels are associated with chronic pancreatitis, gallstones, gastric bypass, celiac disease, diabetes, inflammatory bowel disease, and obesity. Now, the products of protein breakdown, which are valerate, isobutyrate, and isovalerate, are really important in that they give us insight into how well the patient is breaking down and absorbing protein. As your patient eats protein, it starts to get broken down in hydrochloric acid, making amino acids, and then various enzymes that make various peptides, dipeptides, polypeptides. So you have all these different partial proteins. If those partial proteins are poorly absorbed, if they linger in the gut, by the time they get to the colon, they've really mingled with a lot of anaerobes that will putrefy them into products of protein breakdown. So that if you have a high concentration, I know we don't here, but if you had a high concentration, it may indicate malabsorption, maldigestion of protein, but it might also be linked to diet. If your patient is on a high protein paleo diet, then you are likely to see a shift to the right just based on the volume. In this case, we're kind of low, the low 10%. 90% of the reference range population was higher. So what does that mean? Well, it could mean a couple of things. First of all, if your patient is eating protein as a staple of their diet and it's low, then it may mean they're doing a fantastic job digesting and absorbing protein. But it could also mean that they're not eating that much protein. And that imbalance can create an imbalance in the microbiome. So that's a conversation worth having with a finding like this. Is this patient eating enough protein? If the answer is yes, then they're doing a very good job. And fecal fats are very similar. Now, here are all the talking points that I just went through, so you don't have to jot down the notes, but it does speak to malabsorption, maldigestion of protein, the dietary influence, as well as a possible hypochlorhydria, and to check for SIBO and check for inflammation or infection. Again, the fecal fats are similar in that diet matters. So you want your patient to be eating fat in their diet. They must have fat to make, well, so many things, including hormones. If your patient's eating fats and has high concentrations of fat in their stool, that would imply that they are not doing a very good job digesting and absorbing fat because it ended up in their stool. So a high number, again, shifted to the right would speak to maldigestion and malabsorption. But, you know, what if they're on a ketogenic diet and they're eating a high fat diet? Well, then I would expect a shift to the right. In this case, again, the overall total of these different types of fats look low. Now, if the patient is eating fat as a staple of their diet, then they're clearly doing a great job digesting and absorbing because it's not ending up in high concentrations in their stool. However, if they're not eating much fat in their diet, that's a conversation, again, about balance of the diet and finding out why. Maybe they're having issues of bile secretion. Maybe they just feel terrible when they eat fats. These are questions worth asking. So again, for fecal fats, you should have fat in your diet. Triglycerides and cholesterol make up most of our dietary fat intake. They're broken down triglycerides from long-chain fatty acids. are broken down to form long-chain fatty acids. Forgive me. Elevated fecal fats can be caused by exocrine pancreatic insufficiency, bile salt insufficiency, use of PPIs, and hypochlorhydria. Now, the thing I think is really important to remember here is the bile salt insufficiency, because some people will have a really robust pancreatic enzyme finding, so they're secreting enzymes, but really high fecal fats. And the reason may have nothing to do with the digestion based on the digestive enzymes, but a lack of bile. Because if you don't emulsify fats into smaller globules, then the digestive enzymes can't really do a good job. So always think in terms of, with high fecal fats, are they making bile in their liver? Is there a gallbladder issue in terms of how efficiently they're utilizing bile or making it available? And this takes us to our inflammation and immunology section, the eye of DIG. Calprotectin is just a great tool in your toolbox. When you have a patient that comes to you and has all the different symptoms, bloating, gas, transit time issues, and you're thinking, it's probably irritable bowel syndrome, IBS. In the back of your mind, you're thinking, do I need to scope this patient? Am I missing an inflammatory bowel disease, IBD? Now, CalPro is not a substitute for a scope. But if you assume that your patient is not taking an anti-inflammatory, not on an immunosuppressant, if they have a nice low calprotectin, you see the medical decision points to the left of 50. This is a great finding, less than 16. It's highly unlikely that you're dealing with an inflammatory bowel disease. It's not a substitute for a scope, but it is certainly very reassuring to see a nice low calprotectin as far as inflammation is concerned. So the bullet points: it's calprotectin released from intestinal mucosa into the stool in intestinal inflammation. Fecal calprotectin is useful in differentiating IBD from IBS and monitoring IBD treatment. It is not a cancer marker. It is not a substitute for a scope, but can certainly direct the physician to the usefulness of scoping the patient. If you're between 50 and 120 micrograms per gram, it can be caused by infection, history of IBD, and chronic NSAID or PPI use. But greater than 120, refer to a GI specialist to rule out IBD and malignancy. Eosinophil protein X, eosinophils are white blood cells. They're in the stool. They tend to increase in number with various situations, such as certain parasites and worms, such as food allergies. The bullet points: it's elevated with immune-mediated food hypersensitivity, atopic dermatitis, and food allergies. You'll see it elevated in IBD, certain parasitic infections, not always, microscopic colitis, which does require histological analysis for confirmation, can be elevated in children younger than 4 years old. And that takes us to fecal secretory IgA. IgA antibodies reside in the gut mucosal tissue. Therefore, they tend to be your first immune responders to irritation of the mucosa. So, recognized as a first line of defense in protecting the intestinal epithelium from enteric pathogens. Examples include celiac disease, colon cancer, infections, and IBS. Treat root causes of immune regulation, upregulation, and inflammation. Assess for intestinal permeability. Assess food antibody testing. Consider use of an elimination diet. Low secretory IgA may reflect a loss of GI immune response resiliency. So 2 points here. Number one, I mentioned colon cancer as an example, but again, secretory IgA is not a cancer marker per se. Secondly, we used to think low SIGA meant, hey, this is great. There's no reaction, no irritation to the gut lining. But I think that the messaging on that has changed over time, where you may be looking at a lack of immune response in the GI tract, and that's where you might want to consider treatment. And then finally, the gut microbiome metabolites. So for these, we have these short chain fatty acids, which are acetate, N-butyrate, and propionate. And these are really important. These are made when anaerobes break down fiber, resistant starches. And colonocytes depend on short chain fatty acids. They use them, for example, as energy fuel, preferentially over glucose. So you want a high number. This is a low number. You want to be higher up there. And if it's low like this, you want to think about, do I need to give pre and probiotics fiber to increase the overall and resistant starches to increase the what can be broken down with more bacterial activity. So increasing the anaerobes available in the microbiome and increasing the fiber and resistant starch so that they can break those down to make more short chain fatty acids. The percentages give us a sense of how balanced this is all working out. And then finally, the bullet points. So acetate, propionate, butyrate are produced by bacterial fermentation of dietary fiber and resistant starch. They act to maintain intestinal barrier function. They provide fuel for colonocytes, support commensal bacteria, modulated anti-inflammatory and antimicrobial activities. Finally, on this page, we have beta-glucuronidase, which ends in ASE, so you already know it's an enzyme made by anaerobic bacteria. It can recirculate toxins in the gut, and that can be a problem. Estrogen is often an example. It goes through that phase 2 liver the conjugation phase 2 detox glucuronidation pathway. As certain substances like estrogen get detoxed through that glucuronidation pathway, they come out of the liver bound and ready to be eliminated. But if there's a high concentration of beta-glucuronidase, the action of this enzyme is to cleave that bound portion, to recirculate the estrogen instead of eliminate it. The literature does speak to a greater risk of colorectal and breast cancer with high levels of beta-glucuronidase, which are seen in Western diets, especially high protein, high red meat consumption. And there are various ways of trying to address this besides diet. An enzyme produced by colonocytes in the intestinal bacteria can promote recirculation of various hormones and toxins. Its action can therefore increase circulating estrogens. The risk of colorectal and breast cancer may be increased. The Western diet being a problem. Now, in terms of therapeutic considerations, probiotics, dietary fiber, calcium D-glucarate. Most people think of calcium D-glucarate as a way of lowering beta-glucuronidase. Its mechanism of action is really to inhibit the action of beta-glucuronidase. Low-calorie and vegetarian diets are helpful. Konjac noodles are known to inhibit the action of the enzyme. If you go online and Google konjac noodles, they have a 0 glycemic index, I think, and they really also help to block beta-glucuronidase activity, to inhibit it, not necessarily to lower the actual amount. So this is the page I've been talking so much about with data analysis, the commensal. Commensal means at the table, you expect them. It's patterns that really matter here. So they're not inherently pathogenic. Pattern analysis, which we provide on pages 2 and 3, allows for better interpretation of findings. This is PCR. It's a DNA technology. It's quantitative. How many are there? So individual bacteria have unique clinical associations, but the patterns are very important. And we have a PDF in the support guide on the website that lists each of these individually if you want to kind of dig into them individually. And that's what it looks like. And then there's culture. So whereas the page we just looked at, page 5, has the DNA, the quantitative, how many are there, stool culture is how well do they grow out, or do they grow out? And growing out is really a resiliency. Are you resilient enough to grow out? Are you living? The bacteriology includes Lacto, E. coli, and Bifido. Lactobacillus is very hard to grow. Don't be surprised if it doesn't grow, in which case for Lactobacillus specifically, you have to depend a little bit more on the DNA finding on the previous page to at least know what the count is for Lactobacillus. But the others should grow well. Bifido here, 3+ is a good finding. 3 to 4+ is typically what you want to see for this commensal. Then we take the stool and we place it in a culture, and we don't predict or know what will grow out. We just report it. Now, we're always going to list Salmonella and Shigella so that you know we're looking for frank pathogens. But if you see no growth and just a horizontal line, that means it wasn't a finding on the test. But here we do have three. The first is the Klebsiella, which is a 4+ potential pathogen. Whenever you see that yellow, if it grows into the yellow as it has here, a potential pathogen means you might want to treat it, your decision. And if you do, we're going to actually take this specific patient's culture and test it against different antimicrobials and antibiotics to see what was most effective. The bacillus only grew to 1+, so not much growth. Certainly didn't get near 4+. So even though it's a non-pathogen, if it had grown further along, we would have designated it potentially pathogenic. It's our opinion that that's a pretty low number. We can still call it non-pathogenic at that concentration. But whenever you see the yellow, you have to think, do I want to, is it a problem? We don't think at 1+ it is. And then the green straight across tells you, we think it's a commensal. We're not going to give you antimicrobials to kill it, sensitivities, because it's a commensal. And we do the same in the mycology. The mycology is a culture specific to yeast. And you see here for Candida, it only takes a 2+ to get in the yellow. So this is designated a potential pathogen and will provide information for treatment. And then there was a yeast that was very, very low and difficult to identify. If it had been a 4+, the designation would have been changed. We often hear people say, oh, it's so hard to grow yeast. It may not be the best test. We don't feel that that's the case. We think growing yeast is not that difficult, and stand by the mycology as a really excellent tool in seeing what's growing and what it will be sensitive to. And so if we look at this overall, at the additional bacteria, there's our potential pathogen. There's our potential pathogen for yeast. And here's the sensitivity to treat it. So for the Klebsiella, anything in the R box for these prescriptives, it was resistant, did not work well in vitro. Anything in the S susceptibility worked well in vitro and are worthy of your consideration. For the natural agents, the higher the agent inhibits the growth, the more effective. So the further from left to right that gray bar extends, the more effective in vitro. So berberine and uva ursi worked somewhat, but oregano seemed a better choice in the lab based on that reaction. For the Candida findings, we don't give sensitivities for these prescriptives because we have such a mountain of having done this for so many years that we have the statistic. So depending, I believe this was the Cruciae, we can see that it's really the voriconazole that was very effective. The fluconazole was not historically. So that would be a good choice in terms of prescriptives. But we do this low and high for the non-absorbable antifungals. The nystatin worked rather well. You see the berberine, caprylic acid, undecylenic acid, not so well. Garlic better, but the uva ursi seemed the best along with the nystatin for these natural agents. And then the microscopic OMP, ovum parasitology. We take the stool, we put it under the microscope, and we look. And the advantage, look at how many different things we're looking for. With DNA, you can only find what you specifically designed the DNA test to look for. But with this ONP, we can find so many things. If we see it under the microscope, it goes rare, few, moderate, many. In this case, there was a blastocystis at many. So you may note that you have a choice of 1 specimen collection or 3. It's for this page. Remember that parasites are very unpredictable in their shedding. So by giving us 3, it includes an opportunity to cast a wider net. So if you're really concerned about parasites, I think the 3 over 3 different day option is a good way to go. We also look for things like charcoal-laden crystals that come with parasites and white blood cells under the microscope. Again, rare, few, moderate, many. And then the PCR parasitology, the DNA findings. Again, you can only look for what you designed it to look for. So if you're only doing a stool test that has DNA for parasites, you can only detect what you ahead of time decided to find. Here, again, we did detect the blastocystis, which we also saw under the microscope. We also have these additional results for fecal occult blood, and then the patient can report the color and consistency. And then zonulin family peptide is an add-on option. It is related to inflammation and a tendency towards autoimmune issues as well. So combining the PCR, the DNA finding, with the microscopic provides a much wider possibility for detection. Why don't we provide sensitivities for the parasites? We did for the yeast and the culture. What do you think? You don't have that much time, so I'm going to answer that question. It's a great question. The answer is, remember, culture is alive. We can actually see the reaction of the living culture of a bacteria or yeast. How is it impacted by, how susceptible is it to the antibiotic or antimicrobial? When we're looking at parasites, whether it's microscopically, where we're looking at basically body parts and identifying them, or through DNA, where we're looking at the nucleotides that tell us it was there, those aren't living. They tell us they're there, but it would be like taking smelling salts to a corpse. They're not going to move. So you can't do sensitivities for the parasitology, either DNA or under the microscope, because you don't have the living organism to detect change. And then we have, as I mentioned, the occult blood as an add-on to zonulin. So, and these are other additional tests. The macroscopic exam, I think, is a great one. You know, when we get the stool, if you give us, say, the 3 stools, we will take a piece off the 3rd day, put it aside for the DNA, and then we'll blend and filter the rest and look under the microscope. The macroscopic occurs before any of that, where we have a lab tech with experience look at it, eyeball it, and see if there's a parasite, if there's undigested food. This is especially important for those patients that just swear that they look in the bowl and they can see a worm. And that's really the patient that wants you to do that add-on. As far as H. pylori, that's always available. Campylobacter, C. diff, sugar toxin, E. coli, I recommend that when there's an unexplained diarrhea. Fecal lactoferrin, an inflammatory marker, similar to the calprotectin that's included in the test. So here are the key points. And by the way, those are actually my keys. I needed a picture. Evaluation of gut health is a key factor in all aspects of patient health. Providing culture for bacteria and yeast detects living organisms, allowing for sensitivities to enhance protocol design. Parasitology that includes a microscopic and PCR platform casts a much wider net for detection of parasites. Genova's statistical analysis of commensal bacteria enhances pattern analysis and interpretation of findings. And here are some of the support materials that we have. There's a support guide, and at the end of each GI effects, there's actually a link that'll take you right to this. It goes through every single marker on the test that we run for stool. There's also in the back these various charts that go through every one of the commensals on page 5, all the pathogens, bacterial and yeast that we look at, and all the parasites that we look at. And there's always these various ways of looking at webinars on our website. I highly recommend looking at these webinars, and the lab report, which is our podcast, where you get podcasts. So Dr. Chapman, Michael Chapman, and Patty Devers have this wonderful podcast. It's super informative. I highly, highly recommend it. Okay. Thank you so much.